Hello, and welcome to Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. This episode features the second of a two-part series of discussions on best practices for managing patients with advanced ovarian cancer. This episode is also part of a larger educational program entitled Improving Outcomes with PARP Inhibitors in Ovarian Cancer. During this podcast, Dr. Brad Monk from Arizona Oncology, the University of Arizona College of Medicine, Phoenix, and Creighton University School of Medicine at St. Joseph's Hospital in Phoenix, Arizona, and Professor Isabelle Ray Coquard from the Clinical Science Institute of the Centre Léon Bérard in Lyon, France, will discuss the current first-line treatment options for patients with advanced ovarian cancer, focusing on the most recent data for selecting optimal maintenance therapy for specific subgroups of patients. For more information on Dr. Monk and Professor Ray Coquard, along with a link to the complete program, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
So greetings and welcome to this podcast on the frontline treatment of newly diagnosed advanced ovarian cancer. My name is Brad Monk. I'm a gynecologic oncologist from here in Phoenix, Arizona. I'd like to introduce my very good friend and colleague, Isabelle Ray Coquard. Isabella, tell us about your title and welcome.
I'm Isabelle Ray Coquard. I'm medical oncologist and professor of medicine in Lyon, France, in a comprehensive cancer center. And I'm also the current president of the Gynecologic group with the national group dedicated to gynecologic cancer.
So we're here today to talk about newly diagnosed advanced ovarian cancer. Most cases in patients with ovarian cancer diagnosed in advanced stage, most are epithelial and most recur. So we're in this space now where we have sort of had this epiphany that when a patient responds, we need to give them a tolerable, convenient, and efficacious maintenance. In fact, someone said, Brad, it's maintenance treatment because there's cancer there that you're treating. So tell us about what happened in 2011, which is really the first opportunity, and sort of what the uptake has been with the use of frontline bevacizumab, again, with chemotherapy and in maintenance. Is that commonly used in France and Europe as per that approval?
As you mentioned, we are in front of, unfortunately, a very sad disease, and we have to be very careful to consider this patient, to give them all what we can for the management. And the first targeted treatment with reporting benefits in maintenance place was the bevacizumab, because before we never be able to show any benefit using maintenance with chemotherapy, and something that we need to mention. And due to the two big randomized trials, the GOG 218 and the ICON 7 trial, we observed that giving bevacizumab in combination with the standard of care carboplatin plus paclitaxel, followed by the maintenance bevacizumab, we are able to increase the progression-free survival in this population of patients, particularly for patients with a higher risk of relapse, those with residual disease and stage 4. And what we have seen with the GOG 018 is that we increase also the overall survival in the stage 4 group of patients. And this benefit in overall survival, also it is a post-hoc analysis, is a very good signal for the patient in this first line setting.
Yeah, we were a little slower in the U.S. to get that approved, but we ultimately did. It was a very nice opportunity. The problem is that the benefit at the median was 6.2 months, and there was no biomarker. And so we use it, and so now we've pivoted to PARP inhibitors, and that's what I'd like to spend the rest of the time talking about. Really exceptional, unprecedented was this SOLO-1 study, doing now maintenance PARP, but only if you had a germline or somatic BRCA. Is that approved in Europe, and is that commonly used?
In the SOLO-1 trial for BRCA mutated patient, it is already accepted in Europe as in US for germline BRCA mutation, but also for somatic BRCA mutation. And something can be discussed, because how to identify the BRCA mutation can be via the germline and blood sample or via a tumor sample. And SOLO-1 is available in Europe for patients with BRCA mutation in first line, responding to platinum in complete or partial response.
Now, I understand that you can't switch from one treatment to the other. So do you get the BRCA mutation before you start bevacizumab? Because you can't really start bevacizumab and stop it. How does that work in this BRCA mutated group? Because the outcomes are better in the BRCA subset. How do you handle, bevacizumab versus olaparib in the BRCA mutated cohort?
You are very provocative, and it's for this reason we will discuss about PAOLA-1 later. But currently, you are right. We don't have the possibility to use BEV and PARP, so we have to choose. And in fact, the aspect of the BRCA mutation explore via the tumor sample is very easier, because we have the information in 2 weeks. So what's happened in first line when the patient receive surgery for ovarian cancer or celioscopy, the tumor sample is immediately moved to the molecular platform, and we analyze the BRCA mutation. 2 weeks later, when we are discussing about the chemotherapy, we are in capacity to discuss chemotherapy alone, followed by olaparib for patients with BRCA mutation, and chemotherapy plus BEV for patients without BRCA mutation.
That's wonderful. Do you think that's the common occurrence, or do you think your center is an outlier?
No, Brad. Since the PAOLA-1 trial, we have organized national platform in France, and I know it is also the same in Belgium and in Germany, and we are able to have the information on the tumor sample in 2 weeks.
That's great. Well, let's talk about PAOLA-1. So PAOLA-1 is PARP plus bevacizumab. So you don't have to make that decision early on. You start the patient on bevacizumab, and then ultimately you do a test. Maybe you don't. Do you think that the PAOLA-1 approval, I don't expect you to know, is going to be an HRD restricted approval, or do you think it's going to be an all-comer like the way you designed the trial?
Sincerely, Brad, I don't know, because the EMEA currently did not give any information, but looking to that, we have observed with the FDA, looking to that it is two treatment, bevacizumab and PARP inhibitor, looking to the hazard ratio in the HRD positive population compared to HRD negative. I suspect that the EMEA will approve only in the HRD positive population for economic and also high level of efficacy in the HRD population.
Right.
But we have to wait, and we will see what's happened.
So how does that work in Europe if they approve the medication but the test? Does that mean that the test is now paid for all of a sudden, or will they use local tests, which may not be the same as the HRD assay? Homologous recombination repair gene mutations is not the same. How do you see that working itself out?
You're right, Brad. It's that we have to organize in the near future. Currently, the test is not reimbursed.
Right.
And so we have two strategies today. The first is to negotiate to give us an access to the test. But more interestingly, from my point of view, we are using the tumor sample from PAOLA at the ENGOT level, and we have opened an international call to all the labs who are able to design an HRD test, or for example, FOCIRAD 51. And the idea is to develop academic tests able to identify the HRD positive population, and we will validate the test on the PAOLA-1 tumor sample. It is completely free, and I hope that at the end, the less expensive test will be available for all patients in Europe, and I hope at the worldwide level.
I like that. Here's the challenge, is that if you look at the BRCA sort of germline and somatic, maybe at most that's 25%. And then you look at the other homologous recombination repair genetic mutations, that's about maybe 10. But HRD is 50. So you got this extra 15%, which are epigenetic, sort of gene silencing sort of strategies. So it in my opinion, it has to sort of be sort of a loss of heterozygosity. I mean, ovarian cancer is a copy number altered tumor, and so it's not really a mutationally driven tumor, as you've probably taught me. So unless you sort of create this genomic scar assay, looking at the homologous recombination genes may not be adequate.
Yes, you are right, Brad. We have seen in Paula, it is not already published, but we have looked at all the other mutation in the HRD gene panel outside BRCA, including RAD51, including PALP2, and we don't have seen the same magnitude of benefit of the olaparib plus Bev versus Bev in the other genes. So the HRD signature is really specific, and we have to be careful about that. We really need to use a validated test and not only something in-house where we finally not sure about the quality of the test.
I want to talk about the fourth trial, which is PRIMA, which is a 700-patient trial randomizing 2-to-1 to niraparib. That undoubtedly will get labeled as well. There is sort of an incremental benefit. The BRCA patients are the most benefit, but the HRD are close. But in my country, there's an approval in the HRP subset. If it is approved in HRP, so the non-homologous recombination deficient patient, do you think bevacizumab is a better option there, or do you think that niraparib would be an option because that may be the only chance that they can get a PARP inhibitor? I mean, if they don't get a PARP inhibitor frontline in HRP, they're probably not going to be platinum sensitive and respond and be able to get Aerial 3, NOVA, or Study 19. What do you think? It's a complicated question. I get it.
I think it's less complicated than you would say, because if you look at the data from Paula, and specifically in the higher risk group that Philip Harter have presented at the ESMO last year, who finally is quite similar to the patient included in PRIMA with residual disease. We have seen that the median PFS with Bev, also Bev alone, in this group of patients is much more interesting than with a PARP. And my feeling, if we believe in the Paula one, is that in the HRD negative population, probably Bev is more important than a PARP inhibitor, and the median difference in PFS is much higher with using Bev versus nothing than using a PARP. And so if I have the information of the HRP status of the patient, and the patient can receive Bev, I will try to start the Bev immediately, because Bev increased the response rate to chemotherapy, and also we have a median PFS of more than 15 months. It is not what we observe if we use chemotherapy alone, followed by niraparib. But we have also to say that some patients in this population cannot be candidate for Bev for any reason, because of the surgery, because there is some contraindication, because the Bev is not available in some country. And in this case, we know that we have the opportunity to give a PARP to this patient using the data from PRIMA.
Yeah, you and I have talked about this before, but the highest unmet need is in the HRP subset. You just said it. What are we going to do? These trials that we're doing, they're all going to close. We're going to have no clinical trials for these patients. How do we move forward in the discovery of the HRP sort of subset? I'm really interested to hear your answer here.
You know more than me. You know more than me, for sure. But what we can say, unfortunately, HRP is not as homogeneous as HRD. Because there is a lot of different disease in the HRP. We have the cyclin amplification, we have the RB1, we have also the NIR, and probably all other things. And so it will be probably much more complex to find a new target in this group of patients than we have do in BRCA mutated or in HRD positive population. But it is not because it is complex that we don't have to do anything. Probably imagine will give us some information in the HRP group of patients about the immune therapy. Perhaps in this group, immune treatment could be interesting. We also have now new strategy, and specifically, I think to BET inhibitor, who could be an interesting drug specifically in this group of patients. And probably with using the HRD test, we will be able to identify the HRP population. And in this case, it will be easy to do some clinical trial. And it is also an argument to test to use the HRD test in frontline.
For our audience, you mentioned this Imagine. It's Imagine 50. It's bevacizumab plus atezolizumab. And again, they'll look at the subsets, the HRP, HRD, and the PD-L1 expressors. That study was negative, but you're right. Hopefully it will inform us as we move forward. So I really appreciate you letting me ask you these tough questions. The audience can look at the slides, but they want to hear your opinion. So I'm going to ask you one more tough question. In the BRCA mutated population, you have Solo-1 and olaparib, we talked about it. Well, you're also now with PRIMA going to have PRIMA.
Yeah.
So you're going to have to make the decision in the BRCA mutated patient, not if a PARP inhibitor is right, because it is, but which. And so there's three options in BRCA mutated: olaparib, niraparib, or palawan bevacizumab olaparib. What's the right treatment for the BRCA mutated patient?
In fact, with that INEAS report at the SGO this year, we have seen that perhaps also in this population, BEV have some place. And for patients with very advanced disease who can be candidate for BEV, looking to that we report in the PAOLA-1 trial, I have to say that my favorite treatment will be probably the combination of both, specifically for young patients. Now, if the patient is not candidate for BEV, we have two options, the olaparib or the niraparib. Sincerely, I don't see any difference between the two drugs in this group of patients in terms of hazard ratio, in terms of PFS. So in terms of efficacy, the result will be the same. So what we will decide is about the safety profile. And we have now some very good news in terms of option for the patient. We have to look at what is the tolerability to the chemotherapy in terms of hematological tolerability. If we have patients who need some blood transfusion before, or who have some neutropenia or thrombopenia, I will be clearly more in favor to use olaparib. In the opposite, if we have some patient with some digestive side effect with chemotherapy, or we have a lot of comorbidity using some drug could be able to interact with the olaparib, I will move more in favor of the niraparib.
Listen, that's great. So this has been a good conversation about the practical aspects of these four trials: GOG 218, Solo-1, PAOLA-1, and PRIMA. Again, I want to personally thank you for your commitment to your organization, to your patients, to the collaboration between the GOG and NGOT, and appreciate your time today. And thank you to our listeners, and so long for now.
Thank you, Brad. Thank you very much for your energy and your ID and your support.
Thank you.
Thank you very much, Dr. Monk and Professor Ray Coquard, for that excellent discussion, and thanks to you, the listeners, for joining us. Don't forget to listen to the previous podcast episode if you missed the first discussion in this series on biomarker testing for advanced ovarian cancer. As a reminder, to view the full program, Improving Outcomes with PARP Inhibitors in Ovarian Cancer, and to download the slide set associated with this discussion from the Clinical Care Options website, please click on the link in the show notes. As always, thanks for listening.